The Medicare Supplement lie costing seniors $100,000. You've been told all Medicare supplements are basically the same, so just pick the cheapest. That's the lie that can drain $100,000 over 20 years without you noticing until it's too late. Most people plan to switch later, but later often requires medical approval you may not get. In the next few minutes, I'll give you the exact decision path to avoid lifetime overpaying and denial risk. There's one timing rule and one underwriting trap almost nobody tells you. Both are coming up. First, I'll show you how Medicare actually pays your bills so every plan choice after this becomes obvious. Foundation: how Medicare actually pays your bills. The thing most people miss is that Medicare has roles, not products. Once you see the roles, the choices get simple. Original Medicare is your base. A Medigap plan wraps around it. A Part D drug plan protects your wallet on prescriptions. Base, wrap, wallet, that's your mental model. Why does this matter? If you mix up the roles, you pay twice or you leave gaps. I see people thinking a Medigap plan is a network like an HMO. It's not. If a provider accepts Medicare, your Medigap must work there. No referrals, no narrow networks. That's a big access advantage. Let me back up and explain the base. Part A covers inpatient hospital care. Part B covers outpatient services, doctor visits, imaging, surgeries, chemo, durable medical equipment. Medicare pays first, but Medicare doesn't have an out-of-pocket maximum. That's the risk. Coinsurance and deductibles can stack up with no hard cap. Now the wrap. Medigap fills those Medicare-approved gaps. Plans are standardized by letter. A PlanG from one carrier covers the same Medicare costs as a PlanG from any other carrier. The carrier can price it differently and add perks, but the core benefits are identical by law. That means you shop Medigap on price stability and company history, not coverage differences within the same letter. Wallet is Part D. It's separate from Medigap. Part D handles outpatient prescriptions with its own premiums, deductibles, tiers, and preferred pharmacy networks. Drug plans change every year, which is why we review them annually, even if your Medigap stays the same. Before we go further, here's the contrast everyone asks about: Medigap versus Medicare Advantage. With Advantage, a private plan replaces original Medicare for your A and B services. You'll likely have a network, prior authorizations, and an annual out-of-pocket maximum. With Medigap, you keep original Medicare and add a supplemental payer with virtually nationwide access to any provider that takes Medicare. So it's access and predictability versus managed networks and capped annual risk. Neither is right for everyone. In this video, we're focused on Medigap because the cost mistakes there are quieter and longer lasting. The reason this works is that small premium differences and the inability to switch later can compound for decades. Let me show you exactly how the bills flow with a quick example. Say you have a 3-day hospital stay, then 8 weeks of outpatient physical therapy. With original Medicare only, you face the Part A hospital deductible for that benefit period and ongoing Part B coinsurance for PT. There's no overall cap. With a standard Plan G, Medicare pays first, then G pays the Part A deductible and most cost-sharing gaps. Under Part B, after you meet the small annual Part B deductible, Plan G covers the 20% coinsurance. Your out-of-pocket becomes highly predictable. If you had PlanN instead, you'd still pay the Part B deductible, plus up to a $20 copay for certain office visits and up to $50 for ER visits if you're not admitted, and you could be exposed to Part B excess charges in states that allow them. Many states ban excess charges, so in those states PlanN's risk is smaller. We'll talk state rules later. Now, a common confusion: does my Medigap have a network? No. If a doctor accepts Medicare assignment, your Medigap follows Medicare. If a provider doesn't take Medicare, neither Medicare nor Medigap will pay. That's the guardrail. So your practical network is the Medicare universe, which is huge. Here's the shortcut nobody teaches early enough. Decide your structure before you shop carriers. Base, wrap, wallet. Confirm you're staying with original Medicare. Choose your wrap letter for how you want risk split: more premium for more predictability or less premium for some copays and small risks. Then pick your wallet plan annually based on your exact medications and preferred pharmacy. Okay, so what goes wrong? People pick a random cheap Medigap carrier without checking how it prices increases. Or they assume they can start with PlanN and upgrade to G later if their health changes. The The first year you're golden, you have a 6-month Medigap open enrollment window tied to your Part B start when no health questions can block you. After that, most states allow carriers to use medical underwriting. That's where the hidden cost appears, because if you can't pass underwriting later, you're stuck with what you chose. This clicked for me when a viewer emailed about a knee replacement that went fine, but new cardiac meds afterward triggered underwriting denials. They could have afforded PlanG originally. They chose a teaser rate carrier on a plan they didn't want long-term. 2 years later, no switch, premium rose, health changed, door shut. If you remember nothing else from this foundation, remember the flow. Medicare pays first, Medigap fills standard gaps, Part D is separate. Medigap has no networks, coverage is standardized by letter. Your long-term cost is driven less by year 1 premium and more by whether you chose the right letter and a carrier with a sane pricing model, because switching later often isn't guaranteed. Now that the roles are clear, the timing rules will make perfect sense. The enrollment lie: you can always switch later. Now here's where most people mess up. They assume Medigap is like car insurance, you can shop every year and switch with no consequences. That's the costly myth. During your 6-month Medigap open enrollment tied to your Part B start, you have guaranteed acceptance. After that window, in most states, carriers can medically underwrite. Translation: they can say no, charge more, or delay coverage based on your health and prescriptions. Why does this hurt? Health rarely moves in your favor with time. New diagnoses, new meds, a hospitalization, or mobility changes can instantly turn an easy yes into a hard no. The thing most people miss is the door doesn't slam all at once. You don't feel it until you try to switch. Meanwhile, premiums climb and you're stuck paying more for a plan you don't actually want. What's true is simple. You get a one-time, 6-month guaranteed issue window with Part B outside that you only get guaranteed issue protections for specific events, like losing certain other coverage or qualifying under state rules. Otherwise, it's medical underwriting. Companies ask health questions, review prescriptions, and may call your doctors. If you can't clear those gates, there's no obligation for them to take you. Let me show you exactly how the pitch goes wrong. An agent says, start cheap on PlanN, or with this low-rate carrier you can upgrade later if your health changes. Sounds flexible, but it reverses reality. When your health changes is exactly when underwriting gets harder. I've seen mild diabetes that needed an added medication trigger a decline with multiple carriers. A routine stent or a short hospital stay within the look-back period. Often an automatic denial for a while. Even using certain mobility aids or starting oxygen can close the door for good. This clicked for me when a client took a rock-bottom PlanN with an Attained age carrier because it was $30 less per month at 65. At 67, their premium had jumped more than expected, and they wanted PlanG in the interim. They started a blood thinner after an AFib episode. 3 carriers declined. They were healthy enough to live life, but not underwriting healthy. The math flipped from saving $360 a year to costing thousands over time with no escape. Before we continue, you need to understand the difference between marketing and rules. Marketing says switch later. The rules say switch later if you can pass underwriting or qualify for guaranteed issue. Those are not the same, and guaranteed issue rights are narrow and time-bound. Miss the window and it's gone. Here's the shortcut nobody teaches. Plan as if you'll never be able to upgrade. Choose a plan letter and pricing model you can keep for 20 years, not 6 months. If you remember nothing else, remember this: underwriting is the gatekeeper after your first window, not a formality. The reason this works is it forces you to front-load a smart decision while you have maximum leverage. How do you protect yourself? First, don't buy a plan you intend to replace. If you value predictability and full Part B coinsurance coverage, start on PlanG with a carrier known for stable rate history. If you're healthy, understand the risks in your state's rules before choosing PlanN. If you want the lowest premium and can comfortably handle an annual cap, consider High-Deductible G, but only if you truly can self-insure the deductible each year. Second, sanity check your health trajectory. Any history of heart issues, COPD, insulin use, cancer treatment in the last few years, or upcoming surgeries can complicate underwriting. Even new prescriptions can be red flags. If you're borderline, your OEP is your golden ticket, use it. Third, treat "we can always switch" as a red flag. Ask the agent to name the exact guaranteed issue rule that would let you switch to the plan you want outside OEP with no health questions. If they can't, assume underwriting applies and make your permanent choice now. One quick story to make it stick. A viewer delayed upgrading for one more renewal to see if rates stabilized. That year they started insulin. Overnight, top carriers became off limits. They emailed later, "I would have paid a little more at 65. I'm paying a lot more at 70 with fewer options." That's the hidden bill for believing you can always switch later. Once you nail this, everything else clicks. Timing rules aren't paperwork, they're leverage. Your critical windows, OEP, SEP, GI decoded. Now that you see why underwriting is the gatekeeper, timing becomes your leverage. There are 3 buckets you need to decode: your Medigap open enrollment period, your guaranteed issue rights, and other Medicare special enrollment situations that people constantly mix up. Start with your Medigap open enrollment period. This is the big one. It's a one-time 6-month window that starts the first month you're 65 or older and your Part B coverage is effective. During those 6 months, Medigap companies must take you. No health questions, no rate-ups for conditions. No waiting periods for pre-existing conditions if you had continuous prior coverage. This does not repeat every fall. It's tied to your Part B start, not the annual election period for drug or advantage plans. If you delay Part B because you're still on credible employer coverage, your Medigap OEP starts when Part B starts, whenever that is. Miss this window and you shift from guaranteed issue to maybe, depending on your health and your state. Guaranteed issue rights are different. These are specific events that trigger a time-limited no underwriting pass, usually 63 days from the event. Classic examples: your employer group plan ends, your Medicare Advantage plan terminates its contract or you move out of its service area, or you tried a Medicare Advantage plan for the first time and within 12 months you want to return to original Medicare, often called trial rights. In those GI situations, carriers must sell you certain Medigap plans at the best available rate and can't deny you for health. But there are rules. GI doesn't mean any plan, anytime. It's typically equal or lesser benefits and your state may limit which letters qualify. The window is short, miss it and you're back to underwriting. Here's where people get burned. They confuse Medicare Advantage enrollment windows with Medigap protections. The Medicare Advantage open enrollment period from January 1 to March 31 lets you switch MA plans or go back to original Medicare and add Part D. It does not automatically give you Medigap guaranteed issue in most states. You can leave an MA plan during that OEP, but unless you're inside a GI scenario like trial rights or a plan termination, any Medigap application can still be underwritten. So folks leave an MA plan thinking they can grab PlanG with no questions, then get declined and end up with original Medicare and no wrap. That's a nasty surprise. Special enrollment periods are another source of confusion. SEPs are about timing your Part B and Part D enrollment without penalties when you lose employer coverage or move. They're not Medigap protections by default. You can have a SEP to enroll in Part B after retirement and still need to pass Medigap underwriting if your 6-month OEP has already run. The shortcut: OEP is your guaranteed Medigap window tied to Part B. GI is a short, event-triggered backup. SEPs are mostly for Parts B and D timing, not Medigap acceptance. Let me show you how to map this so you don't miss anything. Grab a simple 3-line timeline. On the top line, mark your birthday month and your Part B effective date. Circle the 6 months starting that month. That's your Medigap OEP. On the second line, mark any anticipated changes: planned retirement date, employer coverage end date, or a move. Next to each, write 63 days to remind you that most GI rights are short windows. On the third line, note your Medicare Advantage or Part D milestones: the annual election period in the fall, the MA OEP in the first quarter, and your Part D late enrollment penalty risk if you don't have credible drug coverage. Now layer your state rules. Some states have birthday or anniversary rules that create an extra GI-like window to switch to equal or lesser Medigap coverage without underwriting. Others ban excess charges, which affects the risk profile of PlanN. Don't assume. Call your state insurance department or your SHIP office and confirm your state's exact provisions before you plan to lean on them. Common mistakes to avoid: thinking your Medigap OEP repeats every year, assuming the fall annual election period applies to Medigap, believing the Medicare Advantage OEP gives you automatic GI to buy a supplement, or waiting for one more renewal and drifting past a 63-day GI window after a qualifying event. Another miss: people enroll in Part B mid-year, start their Medigap OEP, but shop slowly and let the 6 months lapse before they pick the carrier and letter they really want. Apply and lock it in while you're inside the window. Don't run out the clock. Here's a quick application example. You retire June 30. Your Part B starts July 1. From July 1 through December 31, you're in your Medigap OEP. Pick your plan letter and carrier with no health questions. If your employer plan ends June 30, you also have GI rights to certain plans for 63 days, roughly through early September, if for some reason you delayed Part B but still lost coverage. If you instead were on a Medicare Advantage plan for the first time starting January 1, and you decide it's not for you by October, your 12-month trial right lets you return to original Medicare and buy certain Medigap plans without underwriting. But if you try an MA plan in year 3, leave during the MA OEP, and you're outside GI, you'll face underwriting for Medigap. The takeaway: time your moves around your OEP, treat GI rights like expiring coupons, and never assume MA or Part D windows protect your Medigap access. Map it once, and you control the rules instead of the rules controlling you. Plan letters that actually matter: GN High-Deductible G. This next part separates beginners from pros. Most of the decision comes down to 3 letters: G, N, and High-Deductible G. Everything else is niche. Focus here and you'll get 90% of the value with 10% of the complexity. Plan G first. Why do so many people choose it? Predictability. After you meet the annual Part B deductible, Plan G covers the Part B 20% coinsurance and takes care of Part A deductibles and coinsurance. No office visit copays. It also covers Part B excess charges in states where those are allowed. The real benefit isn't magic coverage, it's the lack of surprises. If you use care often, this steadiness is sanity. The reason this works is it converts unpredictable coinsurance into a stable premium you can budget. PlanN trims that premium by trading a little cost sharing. You'll still pay the Part B deductible, then up to a $20 copay for certain office visits and up to $50 for ER visits if you aren't admitted. It does not cover Part B excess charges, which is the extra up to 15% some non-participating doctors can bill above Medicare's approved amount. The thing most people miss is excess charges are banned in some states, which makes PlanN more attractive there. If excess charges are banned where you live or where you'll actually use care, N's risk is smaller and the premium discount can be meaningful. High-Deductible G looks scary until it clicks. It's the same benefits as Plan G, but you pay Medicare-approved costs out of pocket until you hit an annual deductible, $2,870 in 2025, then the plan pays like standard G for the rest of the year. Why would anyone choose this? Lowest premiums and a clear annual cap. If you're healthy, have cash reserves, and want to insure catastrophes, HDG can beat both G and N over time, especially if the premium gap is large and rate increases are slower. The game changer nobody talks about is using the premium savings to self-fund the deductible in a separate account. That turns risk into a plan budget. Now, decision levers. Start with the premium spread between these 3 in your zip code and tobacco class. If Plan N is only $8 cheaper than G per month, N rarely pencils out. If N is 15–30% cheaper, it can be compelling, especially in excess charge band states. If HDG is $50 100+ cheaper than N, HDG deserves a look, provided you can comfortably write a $2,870 check in a bad year. Once you nail that, everything else clicks. Next, your expected use. Frequent specialist visits, ongoing therapies, or infusion care. You'll value G's no copay simplicity more. In frequent care and strong cash flow, N or HDG can be smarter. Remember, these plans are standardized. A Plan G is a Plan G no matter the carrier. What changes is premium, rate increase history, and pricing method. That's why you compare letters for risk, then carriers for price stability. State rules matter here. If your state bans Part B excess charges, you immediately remove one of Plan N's unknowns. If your state has a birthday or anniversary rule that lets you move to equal or lesser coverage without underwriting, you get a safety valve to adjust later. Use that to start on N or HDG with a top carrier, bank the savings, and know you have a future window to move within or across carriers to equal or lesser benefits. Common mistakes to avoid. Overbuying Plan F if you're eligible. Yes, it's rich coverage, but premiums are often higher and the Part B deductible it covers is relatively small. Plan G typically offers better value. Ignoring HDG because the word deductible feels scary, run the math with real premiums, then decide. Choosing Plan N in a region where specialists commonly don't accept assignment and excess charges are frequent. Ask your doctor's offices how they bill Medicare before you commit. And the big one, picking the letter by brand hype or a teaser premium without running the 20-year math and checking carrier pricing models. Here's a quick comparison you can try today. Pull 3 quotes per letter from different carriers. Note the monthly premium, the rating method if listed, attained age, issue age, or community rated, and any household discounts. Then estimate your annual out-of-pocket. G is basically the Part B deductible. N adds modest copays and possible excess charges. HDG caps at the deductible. Add premium plus those expected costs and project what happens if premiums rise 5-8% a year. That's the lifetime picture, not the first-year illusion. If you remember nothing else from this section, remember this: pick the letter for how you want to share risk, pick the carrier for how they raise rates. G buys predictability. N buys efficiency if your state and doctors cooperate. High-deductible G buys the lowest premium with a clear cap for people who can self-insure the first dollars. Choose the one you can live with for 20 years. The 20-year cost model, where 6 figures disappear. Before we run numbers, hear why a long lens matters. Premiums don't sit still. Most plans take annual increases from health inflation and the plan's claims experience. If your carrier uses attained age pricing, premiums also climb as you age. That steady creep plus losing the ability to switch creates the 6-figure swing. What do we model? 4 things: premiums today, expected premium increases, realistic out-of-pocket by plan letter, and inflation. Keep it conservative. You're not trying to win an argument, you're trying to avoid a trap you can't undo later. Let's define 2 personas so this sticks. Healthy 65, few meds, a couple of office visits, maybe a test or 2 each year, strong cash reserves. Chronic 65, predictable ongoing care, specialists, imaging, maybe infusion or cardiac follow-up, want stable bills and simple admin. Now the inputs. Pull 3 quotes per letter from reputable carriers in your zip code. Note the rating method, attained age, issue age, or community rated. Grab each carrier's recent rate increase history. Agents and state filings can show this, and it's often more revealing than the first-year price. For Part B deductible and HDG's deductible, use current year amounts and inflate modestly over time. Here's the comparison logic. Lifetime cost equals total premiums paid plus reasonable out-of-pocket under the plan design. For PlanG, assume you pay the Part B deductible annually and little else for Medicare-covered care. For PlanN, add modest office and ER copays, and if your state allows excess charges, budget a cushion. For high-deductible G, assume low-spin years where you pay little out-of-pocket and bad years where you hit the deductible. Blend them based on your health persona. Now the aha. A cheaper first-year premium can lose badly if the carrier's rate playbook is aggressive. Attained age plans often look great at 65 and heavy by 75. Issue age and community-rated plans avoid age-based jumps, though all plans can raise for inflation and claims. So you're not buying a price, you're buying a trajectory. Let's walk healthy 65. Suppose quotes show Plan G at $180 per month, Plan N at $140, and HDG at $70. Assume 6% annual increases for attained age, 4% for issue age community rated. For out-of-pocket, pencil Plan G near the Part B deductible each year. Plan N at the deductible plus a few copays, and HDG at an average. Say 1 year in 5 you hit the deductible, the other years you spend far less. When you compound 20 years, the gap between $180 and $70 with different increase patterns can reach tens of thousands. Sometimes more than $100,000 if the standard G is both higher at the start and escalates faster. That's why HDG can quietly win for healthy, cash-stable retirees when the premium gap is big. Now chronic 65. The value flips. Frequent care means copays stack, and the predictability of Plan G's set it and forget it can pay for itself emotionally and mathematically. If Plan N's discount isn't at least 15-30% in your market, G tends to win on simplicity and total cost. HDG can still compete if the premium gap is massive, but only if you're comfortable writing that deductible most years without stress. 2 common misses blow up the math. First, people ignore how rating method compounds. Attained age with teaser rates often climbs fast, and if health changes lock you in, you ride the escalator. Second, people compare only year 1. You need the 20-year picture because you're likely to keep this plan until something external, state law, or a GI event lets you move. Here's a quick way to compare without a spreadsheet. For each plan letter and carrier combo, write Year 1 premium. Expected annual increase based on rating method and history. Your best estimate of yearly out-of-pocket under that letter. A stress test, add 2 bad years in 20 where N or HDG hit higher out-of-pocket. Sum 20 years for each scenario, the pattern jumps out. One micro story to make it real. A couple picked an Attained age plan N at 65 because it was $35 cheaper than G by 72. Premium increases outpaced the original savings. He had a stent, she started on a biologic. Both were declined for G over the next decade. They paid higher and higher premiums and added copays on top. The math didn't go sideways in year 1, it drifted there slowly, then locked. The quick win, run your scenarios during your 6-month Medigap open enrollment. If you delay, at least get a pre-underwriting check before assuming you can switch. And remember, pricing isn't just the letter, it's the carrier's book, rating method, and history. The checkpoint, choose the plan letter for how you want to share risk, then pick a carrier with a slow, boring rate history and a pricing model you understand. Small differences multiplied by time and health reality, that's where 6 figures go. The carrier trap, attained age, issue age, community rated. Now here, where most people mess up after picking the right plan letter. They ignore how carriers price the same plan over time. 2 PlanGs cover the same benefits, but their premiums age very differently depending on the rating method. Choose the wrong pricing model and your great deal becomes an escalator you can't step off. There are 3 pricing models. Attained age means you start cheaper at 65, then your premium rises as you age, on top of normal annual increases for claims and inflation. Issue age bases your premium on your age when you buy. It doesn't add age-based increases later, though it can still rise for inflation and claims. Community rated charges the same base rate to everyone in an area regardless of age. Again, it can still take general increases. The thing most people miss is you're not buying a price, you're buying a trajectory. Let me show you why this matters. Say Carrier A offers an Attained age plan G at $165 per month at 65. Carrier B offers an issue age plan G at $185. Year 1 looks better. But if a averages bigger increases, age plus trend, while B only takes trend, the lines cross. By your mid-70s, A can be the expensive one. If you can't pass underwriting later, you're stuck with the climber. Before we continue, you need to understand what drives increases regardless of rating method. Health inflation pressures claims. The plan's pool, how healthy or sick it is, matters. Carriers also run book strategies. They open a new block at low rates to attract healthier members, then close it later and let that closed block age in place with higher increases. That's not illegal, it's just how the business works. Therefore, the first-year premium tells you almost nothing without context. Here's the shortcut nobody teaches. Read the carrier, not just the quote. Ask your agent for the rating method for your specific state and plan letter. Look up state rate filings or ask for a 3 to 5 year increase history for that carrier and plan. Some carriers consistently post modest, steady increases. Others look like a roller coaster. A boring carrier with predictable 3-5% bumps can beat a flashy teaser with 8-12% swings, even if boring starts higher. Now, how do you compare apples to apples? Do a quick glide path test. Take the year 1 premium for each carrier and apply a realistic annual increase based on the rating method and the carrier's history. For an attained age policy with a hot book, pencil 7-10%. For a well-run issue age or community-rated book, pencil 3-6%. Then look at years 5, 10, and 15. Would you still be comfortable paying that number if you couldn't switch? If not, pass. A common mistake is chasing household or early enrollment discounts without reading the fine print. Some discounts phase out after a year or require both spouses to stay on the same carrier. When the discount drops off, your effective increase can feel like a jump. Another miss is ignoring tobacco class. Some carriers aggressively surcharge tobacco users at issue, then stack larger increases. If you can quit and reclassify during your guaranteed window, do it before you apply. Let me give you a micro story. A viewer grabbed the lowest attained age plan and at 65 because it was $28 less per month than a community-rated option. By 70, their premium had drifted above the community-rated plan's current price. They had a minor heart event and a new prescription. 3 declines later, they were locked into the faster escalator. The savings vanished not in one big move, but in slow motion. What about community-rated states? Community-rated can be great for late entrants because age doesn't penalize you at purchase. But community-rated still varies by carrier and market health. You still need to check increase history. Issue age behaves similarly. The absence of age-based bumps doesn't mean the plan never increases. It just means increases are tied to trend and pool, not birthdays. One last guardrail: never assume the national brand is automatically safer. Large carriers run multiple books by state. One state's book may be stable while another runs hot. Ask for state-specific history, not anecdotes. And if your state has a birthday or anniversary rule that lets you switch to equal or lesser benefits without underwriting, use that window to upgrade carriers within the same letter if your book starts climbing. If you remember nothing else here, remember this: pick the letter for risk sharing, then interrogate the carrier's pricing model and history. You're buying a 20-year glide path, not a headline price. Choose the slow, boring escalator you can ride, not the fast one that traps you halfway up. Underwriting reality: what gets you declined? Before we continue, you need to understand how underwriting actually works once you're outside your open enrollment or a guaranteed issue window. Companies aren't guessing. They use applications with knockout questions, look-back periods, and prescription checks. Answer yes to the wrong item and it's an automatic decline or a postpone. The reason this matters is simple: you won't know you're uninsurable until you apply, and by then your options may have shrunk. What gets attention first are recent events. Hospitalizations or emergency visits within the last 90 days to 12 months are common pause points. Scheduled but not yet completed surgeries or tests: that's usually a hard stop until everything's done and stable. Any new oxygen use, a recent fall with injury, or the addition of mobility aids like a walker can also trigger declines at many carriers. The theme is stability. Carry risk today, and you're likely a no today. Now the chronic conditions that frequently cause automatic declines. COPD and other serious lung diseases live near the top of most lists. Recent heart events, heart attack, stent, bypass, valve replacement, stroke, or TIA often mean a waiting period or a decline for a set number of years. Active or recent cancer treatments are a common no for a while after last treatment. Insulin-dependent diabetes, especially with complications like neuropathy, retinopathy, or cardiac issues, is frequently uninsurable. Progressive neurological conditions, Alzheimer's, dementia, Parkinson's, MS, ALS, are almost universally declined. Medications tell a story and carriers read it. Underwriting teams scan pharmacy databases to see what you've been prescribed, not just what you remember. Blood thinners after a heart rhythm issue, certain strong psychiatric meds, oxygen-related supplies, or infusion biologics can be red flags. Even if you feel fine, the RX list can signal a risk pattern the carrier doesn't want in its pool right now. Look-back windows matter. Many applications ask ever for some diagnoses in last 2 years or last 5 years for others. A cancer diagnosed 3 years ago with no recurrence might be okay with one carrier and not with another. A stroke 2 years ago could be an automatic decline at carrier A, but a possible postponed review at carrier B after more time passes. That's why state and carrier variability is real, but the overall pattern stays consistent. The sicker and more recent the issue, the tougher the pass. Age tightens the screws. Some carriers grow stricter after 70, especially if there's any cardiac or pulmonary history. Others will underwrite into the late 70s, but with less tolerance for combined risks. You'll also see tobacco class surcharges that make switching less appealing, even if technically approved. Remember, being approved at a rated-up price can still feel like a practical decline if the premium is far above what you expected. Here's the shortcut nobody teaches: pre-underwrite before you apply. A good broker can run your conditions and meds against multiple carriers' guidelines and tell you where you likely stand. If you're borderline, apply while you're within any guaranteed window you can use. Part B 6 months, state birthday or anniversary rules or trial rights. If there's an elective surgery on your calendar, decide on your Medigap move first. Don't wait until post-op meds complicate the file. Common mistakes to avoid: don't test the waters with multiple applications at once. Too many pulls can spook carriers, and each decline is a data point. Don't omit meds or diagnoses. Underwriting sees the pharmacy data and medical records. An omission reads worse than a disclosure. Don't assume one decline means all declines. Guidelines vary. But also don't assume a different carrier will say yes if the issue is a universal knockout like oxygen use or insulin with complications. Micro story: a viewer had mild diabetes managed with pills at 66 and stayed on a cut-rate Attained age PlanN at 68. An AFib episode put them on a blood thinner and rate control meds. They tried to move to PlanG. 3 carriers reviewed the file and declined. Recent heart event plus new meds. Within 2 years, the premium had climbed and the copies piled up. Their words: "I didn't know I had to be underwriting healthy, not just living healthy." That's the difference that locks people in. If you remember nothing else, remember this: underwriting values stability, recency, and risk pattern. Apply while healthy, pre-check the rules, and treat every guaranteed window like gold. Once you're outside it, the gatekeeper decides whether you can afford to change. Future-proofing your choice, safe harbor strategy. You can't predict your health 5 years out, but you can choose a setup that won't punish you if life happens. Think of this as building a safe harbor, a plan letter you can live with for 20 years, a carrier that raises rates slowly, and a way to keep flexibility if underwriting shuts later. Start with the anchor. Pick a plan letter you could keep if you never qualified to upgrade. If full predictability and access matter most, PlanG is your anchor. If you're healthy and comfortable with small copays, PlanN can be a smart anchor, especially in states that ban excess charges. If you're cash stable and want the lowest premium with a defined cap, High-Deductible G is the efficiency anchor. The point isn't perfection, it's choosing the letter you'd still tolerate if underwriting said no next year. Now pair the anchor with a pricing model you understand. Ask your agent, is this Attained age, issue age, or community rated in my state? Then ask for recent rate increase history for that exact plan letter. You're looking for boring. I'd take a slightly higher starting premium with steady 3-6% bumps over a teaser rate that's jumped 8-12% in past years. Remember, standardized benefits mean you're paying for the glide path, not new coverage. Here's the ladder logic that gives you flexibility without gambling. If you lean efficient, start with PlanN or High-Deductible G from a top 3 carrier in your area with solid rate history. Open a separate savings bucket, call it your deductible fund, and automatically move the premium difference you're not spending each month into that fund. That turns potential risk into cash you control. Each year during your Part D review, also check whether your state offers a birthday or anniversary rule. If it does, set a reminder to shop for equal or lesser benefits with no underwriting during that window. That's your step to a better priced carrier, or in some states, a lateral move to the same letter at a lower rate. If you lean predictable, start with PlanG, but still map a what-if lane. If your state has a birthday or anniversary rule, you can move to equal or lesser coverage later without health questions. That's your safety valve if your carrier's increases start running hot. If your state doesn't have those protections, you're relying on your initial carrier choice and any future GI events, so be extra choosy about the pricing model and book history up front. A practical move most people miss: pre-underwrite your future. Ask your broker to run your current meds and diagnoses against several carriers' guidelines right now while you're healthy. If one carrier is notably more lenient on your profile, weigh that as a tiebreaker. You may never need it, but if you do, you'll be glad you're already with the carrier most likely to keep you. Let's talk cash flow, because it's the lever you control. If you choose High-Deductible G, automate savings of at least the monthly gap between HDG and Standard G into a dedicated account. In a bad year, you pull from that account to cover expenses up to the deductible. In a light year, the fund grows, effectively reducing your long-term cost. With PlanN, do a simpler version. Set aside a small monthly amount for copays and a cushion for occasional excess charges unless your state bans them. Either way, you transform uncertainty into a budget line. Now here's where most people mess up. Churning carriers every year, chasing a $5 difference. Frequent switching can land you in a weaker risk class, strip discounts, and complicate claims. Instead, set a rule. You'll only move if 1. Your year-over-year increase beats your state's average by several points. 2. You can switch under a GI window like birthday or anniversary rules, or you've pre-qualified through underwriting. And 3. The new carrier's 5-year history looks measurably steadier. If those 3 aren't true, sit tight and recheck next year. Build a state-specific safety checklist. Confirm whether your state bans Part B excess charges. If it does, PlanN's risk drops. Verify if you have a birthday or anniversary rule and the exact window. Some states offer 30 days before and after a date, others limit ages or carriers. Write those dates on your calendar now. If your state has no extra protections, treat your initial 6-month Medigap open enrollment as your primary, and maybe only shot at picking your forever plan letter and carrier. 2 micro stories to ground this. One viewer started on High-Deductible G in a community-rated state, banked $90 a month, and used the birthday rule to switch carriers twice over 7 years without health questions. When a rough year hit and they met the deductible, the savings fund paid it, and their long-run costs still beat Standard G by thousands. Another viewer picked PlanN in a state that allows excess charges, but confirmed all their doctors accept assignment. Over 5 years, the copays were trivial compared to the 20% premium gap. When their carrier's increases spiked, they used the anniversary rule to slide to an equal plan with a calmer carrier. Your safe harbor has 3 parts: an anchor letter you won't regret, a slow and steady carrier, and a rules calendar that creates future no underwriting exits. If you set those up now and automate the savings from any premium discount, you'll weather rate cycles, health surprises, and marketing noise without getting trapped. The state rules that change everything. State rules are the hidden variable that can either save you thousands or trap you. Medigap is federally standardized for benefits, but states control extra protections, switching windows, and whether doctors can bill excess charges. Once you see your state's levers, your plan letter choice and carrier strategy get a lot clearer. Start with birthday and anniversary rules, the quiet safety valves. In California, Oregon, Maryland, and Illinois, you get a birthday period window to switch to equal or lesser Medigap coverage without medical underwriting. The exact timing varies, often your birthday month or a defined window like 45 days around it, sometimes with age limits or carrier restrictions. Missouri takes a different angle with an anniversary rule. Around your policy anniversary, you can switch carriers at the same coverage level without health questions. Why does this matter? If you start on PlanN or High-Deductible G and your carrier's rates heat up, these windows let you recalibrate to a calmer carrier later, no underwriting stress. Next, excess charge bans. PlanN doesn't cover Part B excess charges, but several states don't allow providers to bill them in the first place. If you live and get care in a state that bans excess charges, you remove a major unknown from PlanN's risk. That can tilt the math toward N if the premium gap versus G is meaningful. If your care crosses state lines, check where you actually see doctors. Bans protect you where you receive services, not where you sleep. Community rating is another state lever you need to know about. Some states push insurers toward community-rated pricing, which means your premium isn't higher just because you're older. That can be a big deal for late entrants or people worried about age-based jumps. It doesn't mean rates never rise, trend and claims still apply, but it changes the glide path versus attained age states where birthdays stack increases. Guaranteed issue specifics also vary. Federal rules give you a one-time 6-month Medigap open enrollment tied to Part B, plus narrow GI events like MA trial rights or plan terminations. States can expand on these. Some add their own GI windows after certain moves, employer coverage loss details, or within birthday anniversary periods. Others restrict which plan letters you can choose during GI, often equal or lesser benefits compared to what you had. If you intend to lean on a GI rule later, verify the exact letters allowed in your state so you don't plan on moving to G and find out only D or N is offered. Here's how to act on this without getting lost. Build a state-specific checklist before you pick your plan letter and carrier. Call your state insurance department or your SHIP office and ask 5 questions. Do we have a birthday or anniversary rule for Medigap? What's the exact window, ages, and limitations? Which plan letters are eligible during that window? Can I switch carriers or only plans within the same carrier? Are Part B excess charges banned statewide? If not, how common are non-participating providers locally? What pricing models are common here? Attained age, issue age, or community rated? And does the state require any of them? During GI events, which plan letters must carriers offer, and what's the timing? Usually 63 days from the qualifying event. Now plug those answers into your decision. If you have a birthday or anniversary rule, you can be more aggressive starting on N or high-deductible G with a strong carrier, knowing you've got annual or periodic off-ramps without underwriting. If you don't have those protections, treat your 6-month open enrollment as your main shot and bias toward the letter you'll happily keep for 20 years. Often G for predictability or HDG if the premium spread is huge, and you can self-fund the deductible. Don't copy a friend's plan from another state. A PlanN that's perfect in a state with excess charge bans and a birthday rule might be the wrong call in a neighboring state with frequent non-participating specialists and no GI windows. Same letter, different rules, very different lifetime cost. One quick example. In a birthday rule state with excess charges banned, PlanN from a stable, community-rated carrier can be a sweet spot. Lower premiums, minimal copy exposure, and a built-in window each year to move to an equal plan if rates spike. In a state with attained age pricing, no birthday rule, and specialists who don't accept assignment, PlanG from a carrier with steady history is usually the safer permanent anchor. And in markets where high-deductible G is $80 to $120 cheaper per month than G, pairing HDG with a rules calendar and a dedicated savings bucket can outperform, especially if your state lets you switch later without underwriting. 2 mistakes to avoid. First, assuming the Medicare Advantage open enrollment window gives you Medigap guaranteed issue. It usually doesn't unless you're in a specific GI event like trial rights. Second, waiting past a 63-day GI window after a qualifying event. Those are hard deadlines, miss them, and underwriting returns. If you remember nothing else, remember this: your state's rules decide your exit doors. Learn them up front, write the dates on your calendar, and choose your plan letter and carrier in a way that uses those doors so you never get trapped paying more for less. Part D done right, the silent budget killer. Now let's tackle the line item that blows up more retiree budgets than anything else. Part D, your drugs. Here's the truth most people miss: drug plans change every year. Premiums move, formularies shuffle, tiers, pharmacies switch from preferred to standard, and prior authorizations appear out of nowhere. If you set it and forget it, costs can double or worse without any change to your prescriptions. Why this matters right now: since 2025, there's a $2,000 annual cap on Part D out-of-pocket for covered drugs. That's great protection, but it's not a reason to sleep on the details. You can still waste thousands by sitting in the wrong plan with the wrong pharmacy. The reason this works is simple: plans steer you with tiers and networks. If you swim against the current, you pay for it. What should you actually evaluate? 5 things in this order. Your exact medications and dosages. Each plan's formulary placement for those meds, tiers, and restrictions. The plan's preferred pharmacy network status for your go-to store. Deductible structure: does it apply to all tiers or only higher tiers? Premium versus total annual cost, because the lowest premium is often not the lowest total. Let me show you exactly how to do this without guessing. Once a year during the fall annual election period, go to the Medicare Plan Finder or a reputable quoting tool. Enter every drug, dosage, and frequency. Add your favorite pharmacies plus 1 or 2 big box or mail order options. Sort by lowest drug plus premium cost. Don't stop at the top line, click into the plan details and look for prior authorization, step therapy, and quantity limits on your specific meds. If you see restrictions, ask your prescriber now about alternatives on a better tier or the paperwork required. That 10-minute check saves months of hassle. Here's the shortcut nobody teaches. Start with pharmacy, not plan. If your everyday pharmacy isn't preferred for a plan, switch pharmacies or switch plans. The price gap between preferred and standard can be massive on common generics and painful on brand name drugs. I've seen the same script cost $6 at a preferred pharmacy and $42 at a standard one every month. Multiply that by a year. Common mistakes that cost real money. Picking based on premium alone. A $10 cheaper premium can hide a $400 higher annual drug bill due to tiers. Ignoring the deductible. Some plans waive deductibles for Tier 1-2 generics, others don't. If you mostly take generics, a low or waived generic deductible is a win. Not checking mail order pricing. For 90-day fills, mail order can be dramatically cheaper, but only when the plan's own mail partner is preferred. Missing prior auth and step therapy. If your med needs approval, don't wait until the pharmacy rejects it. Get your prescriber to submit the form before January 1. Now a practical example. You take 3 generics and 1 brand. Plan A has a lower premium, but your brand is Tier 4 with step therapy and your local pharmacy is standard. Plan B has a slightly higher premium, but your brand is Tier 3, no step therapy, and your pharmacy is preferred. On annual total cost, Plan B wins by hundreds. That's why premium shopping is the wrong game. What about the $2,000 cap? It's a safety net, not a strategy. If you're on expensive brands or injectables, the cap stops the bleeding, but your path to that cap can still be smoother or rougher depending on tier and network. Your goal is to minimize the road to the cap and avoid denials, not just accept it. Micro story: a viewer kept the same plan 5 years running. Their pharmacy lost preferred status, 2 generics moved up a tier, and a new prior auth delayed their refill. Their annual cost went from $480 to over $1,600 with the same meds. One 12-minute review and a switch to a plan where their pharmacy was preferred dropped the total back under $600. Here's your annual playbook. 2 weeks before the fall window, print your med list from your patient portal and verify dosages. Run 3 pharmacy scenarios, your nearest, a big box, and the plan's mail partner. Pick based on total cost and restriction friction, not just premium. After enrollment, schedule January refills early and confirm prior auths are on file. Set a reminder every September, run Part D check. If you remember nothing else, remember this: Part D is a yearly shopping trip. Enter exact meds, choose a preferred pharmacy, and buy the lowest total cost with the fewest hoops. That's how you keep your budget and your refills under control. The decision tree: pick your plan in 12 minutes. Decision fatigue is real, so here's a fast, clean flow that gets you to a confident choice without second guessing. Start the clock. Minute 1, confirm your structure. You're staying on original Medicare and adding a Medigap wrap plus a Part D plan. Good. Now it's letter first, carrier second. Minute 2 to 4, pick your branch. If you want maximum predictability and access, choose PlanG. If you're comfortable with small copays and your state bans excess charges or your doctors accept assignment, choose PlanN. If you want the lowest premium with a clear annual cap and you can self-fund up to the High-Deductible, choose High-Deductible G. Minute 5, sanity check the premium spread in your zip code. If N isn't at least roughly 15% cheaper than G, N usually isn't worth the trade-offs. If HDG isn't at least $50 to $100 cheaper per month than N, HDG likely won't move the needle. If those gaps look solid, keep going. Minute 6, check state rules quickly. Do you have a birthday or anniversary rule that allows equal or lesser coverage switches without underwriting? If yes, you've got a safety valve. If no, treat this decision as long-term. Minute 7 to 8, shortlist carriers. For your chosen letter, pull quotes from 3 reputable carriers. Note rating method: attained age, issue age, or community rated, and ask for 3 to 5 year rate increase history. Favor boring, steady increases over shiny intro prices. If a carrier offers a household discount, confirm the rules and whether it phases out. Minute 9, underwriting reality check. If you're inside your 6-month Medigap open enrollment tied to Part B, apply now, no health questions. If you're outside it, have a broker pre-underwrite your current meds and diagnoses with those 3 carriers. If you can't pass underwriting, pause and see if any GI window applies. No GI, reevaluate branch choice you can keep. Minute 10, do the mini math. For each finalist, estimate year 1 total. PlanG, premium plus the Part B deductible. PlanN, premium plus the Part B deductible, a modest bucket for office and ER copays, and a small cushion if excess charges are possible where you get care. High-Deductible G, premium plus a realistic average out of pocket. Assume you might hit the deductible in a bad year and plan for it. Minute 11, choose the glide path, not the headline. If 2 carriers are close, pick the one with steadier increases and a rating method you understand. If you're choosing HDG or N, set up an automatic monthly transfer of the premium savings into a deductible fund. That turns risk into a budget. Minute 12, lock it in. Submit the Medigap application first, then enroll in Part D so you don't create a gap. Set calendar reminders for your state's birthday or anniversary window, if any. Each fall's Part D review. An annual Medigap rate check against current market pricing. A few mistake-proofing checkpoints. Verify your Part B effective date and confirm you're inside OEP or a GI window before assuming no underwriting. Don't chase a teaser rate from an attained age carrier without seeing their increase history. Confirm your doctor's Medicare billing status if choosing PlanN in a state that allows excess charges. If you're a tobacco user, ask how the carrier treats tobacco class now and later. Quitting before you apply can save you for years. Avoid overlapping coverage. When your new Medigap is approved with an effective date, cancel any prior Medicare Advantage plan appropriately. Line up Part D the same month your Medigap starts. Here's how the branches look in one sentence each. Need maximum predictability and nationwide flexibility. PlanG with a stable carrier is your move. Comfortable with small copays and low excess charge risk. PlanN from a top 3 carrier can save real premium. Want the lowest premium and can self-insure first dollars with a hard cap. High-Deductible G plus an automated savings bucket is efficient. One micro story for confidence. A viewer ran this exact flow at 65. Chose HDG because the spread versus G was $110 per month. Community-rated state, solid carrier history. They auto-saved the difference. In year 4, they hit the deductible after a surgery. The fund covered it. Over 5 years, they still sat thousands ahead compared to standard G, and they had a birthday rule backup if rates turned. If you're outside OEP, add one guardrail, get a soft pre-check before you emotionally commit. If underwriting says maybe, have a Plan B carrier lined up. If it says no, use your state's rules or a GI event if available. If none apply, pick the branch you can keep without stress. That's the 12-minute decision tree. Letter for risk sharing, carrier for rate trajectory, locks for timing, savings automation if you choose N or HDG. Apply Medigap first, then Part D. Set your reminders and you're done. Implementation checklist. Do this in the next 14 days. Let's turn this into action. Over the next 2 weeks, follow this checklist so you lock in coverage while your leverage is highest. Day 1, verify your Part B effective date. Look at your red, white, and blue Medicare card or your Social Security account. Circle the month Part B started. That starts your 6-month Medigap open enrollment. If you're still inside it, you've got guaranteed acceptance. If you're outside it, note that you'll need underwriting or a guaranteed issue event. Day 2, confirm your window. If you're within your 6 months, set a calendar reminder for 2 weeks from today, your decision date. If you're outside, call your state health insurance assistance program and ask if you have a birthday or anniversary rule or any current GI rights. Write the exact dates. Day 3, gather your info. Print your medication list with dosages and frequencies, your doctor's names and locations, and any recent hospitalizations or surgeries. Add your tobacco status and preferred pharmacies. This packet drives quotes, underwriting pre-checks, and Part D comparisons. Day 4, pick your plan letter using the decision tree. If you want maximum predictability, favor Plan G. If you're comfortable with small copays and your excess charge risk is low, consider Plan N. If you want the lowest premium and can fund the deductible, evaluate High-Deductible G. Decide today so you don't drift. Day 5, check state levers. Confirm whether your state bans Part B excess charges and whether you have birthday or anniversary rules. If excess charges are banned, Plan N's risk drops. If you have switching rules, note those windows for future no underwriting moves. Day 6, shortlist carriers. Get 3 quotes for your chosen letter from reputable carriers. For each quote, record the rating method: attained age, issue age, or community rated, any household or bank draft discounts, and a 3 to 5 year rate increase history. Favor boring, steady increases over shiny teasers. Day 7, do a mini 20-year check. Take each carrier's premium and apply a realistic annual increase based on its method and history. Ask, would I be comfortable with this number at year 10 if I couldn't switch? Eliminate climbers that look cheap now but steep later. Day 8, underwriting pre-check. If you're outside OEP, have a broker run your meds and diagnoses against those carriers' guidelines. Don't apply blind. If you get a likely approve, proceed. If you get a maybe, identify a backup carrier. If you get no, see if any GI window applies before you change anything else. Day 9, confirm provider acceptance. Call your key doctor's offices and ask 2 questions. Do you accept Medicare? Do you accept Medicare assignment? If you're leaning Plan N in a state that allows excess charges, assignment acceptance lowers your surprise risk. Day 10, enroll in Medigap first. Submit the Medigap application with your desired effective date. If you're inside OEP or GI, there are no health questions. If you're being underwritten, pause other changes until approval lands. choose bank draft to avoid missed payments and to get possible discounts. Day 11, set up your deductible fund if you chose N or HDG. Automate a monthly transfer equal to the premium savings versus standard G into a separate savings bucket. That turns risk into a budget and covers copays or the high deductible without stress. Day 12, choose Part D by total cost, not premium. Use the Medicare Plan Finder. Enter exact meds and dosages, compare plans at 3 pharmacies, your usual store, a big box, and mail order. Sort by lowest total annual cost. Check for prior authorization and step therapy. Pick the plan with the fewest hoops at the lowest total. Day 13, align effective dates and cancel correctly. Make your Part D start the same month as your Medigap. If you're leaving Medicare Advantage, ensure your Medigap approval and start date are final, then coordinate the MA disenrollment to avoid overlap or gaps. Keep confirmation letters. Day 14, calendar your maintenance. Add 3 recurring reminders. Each September, run a Part D check. Each year, compare your Medigap premium to current market rates. And if your state has a birthday or anniversary window, set alerts 30 days before it opens. That's how you use rules, not fear. Quick fixes if something goes sideways. If you see a shock rate increase, verify whether an initial discount ended. If a bill looks wrong, call Medicare and your Medigap carrier and request a claims review. If a prescription denies in January, ask your plan for a transition refill and have your prescriber submit prior authorization immediately. Follow this 14-day sprint and you'll go from guessing to locked in, with future exits on your calendar. First-year pitfalls, rate jumps, network confusion, billing errors. Your first year sets habits that either save money or quietly lock in waste. 3 traps show up over and over: rate jumps you didn't see coming, network confusion that blocks care, and billing errors that snowball if you don't fix them fast. Let's start with the rate jump. Many carriers use intro discounts, household credits, or early enrollment perks that phase out after a few months. It can look like a shocking increase when really a discount ended. The fix is simple. Before you buy, ask, what discounts are built into this quote? When do they end? And what will my bill be in month 13? Put that number on your calendar now. If the year 1 increase is out of line with the carrier's history, decide during your first-year windows whether you'll switch under a birthday or anniversary rule or stay for the glide path you expected. Now the network confusion. Medigap isn't a network plan. If your provider accepts Medicare, your Medigap pays per the plan benefits. The common mistake is treating Medigap like Medicare Advantage, calling to ask, are you in network for XYZ, and getting bad answers from front desks that only know managed care scripts. Ask the precise questions. Do you take Medicare? And do you accept Medicare assignment? That second question matters most if you chose PlanN in a state that allows excess charges. If a specialist says no to assignment, you may face up to 15% excess charges on Part B services. PlanG covers them, PlanN doesn't. Confirm this before your first appointment, and if needed, choose an assignment-accepting provider to avoid surprises. Billing errors come next, and they're fixable if you act quickly. The classic mess is overlapping coverage during a switch. If you left Medicare Advantage and started Medigap but your MA plan didn't properly terminate, you can get double billed or see claims routed to the wrong payer. The fix: line up effective dates. Medigap and Part D should start the same month, and keep written confirmations. If a bill looks wrong, call Medicare and your Medigap carrier with the claim number and ask for a coordination review. Keep a simple log: date, person, case number. Promise that paper trail speeds corrections. Another billing miss is the Part D late enrollment penalty when people assume Medigap covers drugs. It doesn't. If you don't have creditable drug coverage, enroll in Part D when Medigap starts. Even if you take no meds, choose a low premium plan to avoid penalties later. Also, use automatic bank draft for both Medigap and Part D premiums. Missed payments can trigger policy lapses, and re-enrollment later may mean underwriting for Medigap or waiting until fall for Part D. Here's where most people mess up paperwork. They submit the Part D application first, then Medigap, then try to cancel an Advantage plan mid-month. Reverse that. Apply for Medigap first, get the approval and start date, then enroll in Part D to match the same month, and finally coordinate the Advantage disenrollment so there's no gap or overlap. If you see a denial at the pharmacy in January, ask for a transition fill and have your prescriber file prior authorization immediately. One more first-year blind spot. Confusion over explanation of benefits versus bills. Your EOB isn't a bill. Wait for the provider invoice after Medicare and Medigap settle. If the provider's bill doesn't reflect the Medigap payment, call the provider's billing office and ask them to rebill with your Medigap information. Sometimes the carrier didn't receive the electronic crossover, especially on first claims. Give them your Medigap ID and ask for a rebill. It's routine. Quick wins to lock in good habits. Set calendar alerts for premium due dates and your first policy anniversary. Save PDFs of your Medigap and Part D ID cards and carry physical copies to the first visits. Call your top providers once to confirm Medicare acceptance and assignment. Note answers. Review your first 3 EOBs to ensure the crossover works. If not, call the carrier to enable it. If you address these in month 1, you prevent year 1 confusion from becoming year 10 cost. Small setup steps now save you from paying more for the same care. Here's the takeaway. Front-load smart choices during your Medigap open enrollment and build a slow, predictable glide path, because switching later often needs health approval you might not get. If you want my state-by-state rules checklist and a fill-in 20-year cost calculator, subscribe and watch the next video where I walk through real quotes and scenarios step by step. Lock this in now. Your future self will thank you.